causes of predominance of longitudinal lie and cephalic presentation. Why? The cephalic presentation, I told in my previous class, the cephalic presentation and longitudinal lie will be in 99.5% cases. The presentation like lie is longitudinal lie. That means axis of the uterus is parallel to the axis of the fetus. Why this predominance is there? We'll see the reason behind this. The fetus is the attitude of flexion assumes the shape of the ovoid. I said in my previous video that the fetus, each part of the fetus is flexed and occupies the ovoid shape with a long verticocaudal axis measuring about 25 cm, long axis measuring 25 cm. At a term it will be flexed. The attitude of the fetus is completely flexed. And it will be longitudinal lie. This is uterus and this is the fetus. It will be like this. The fetus accommodates comfortably along the long axis of the ovoid shape. Uterus also will be ovoid shape. If the fetus is flexed, this is also ovoid shape. This can occupy at the term. It will be completely filled. If only fetus present like this will be comfortable. So comfortable like so ovoid shape of the uterine cavity at the term. Hence there is a predominance of longitudinal. So the most of the cases you'll see the longitudinal lie. Did you get the like what I'm saying? This is a uterus. This is ovoid shape. The fetus at term completely flexed and also occupies the ovoid shape. If it lies, it becomes discomfort. So this is more comfortable position for the fetus. So at term most of the fetus presents as longitudinal lie, which corresponds to parallel to the axis passing to the uterus will be parallel to the axis passing to the fetus. And this is about the why the predominance of longitudinal lie and cephalic presentation is more common. Now longitudinal lie is more common. Now we will see why the cephalic presentation is more common. See, cephalic presentation being the absolute majority among the longitudinal lie, it can be explained by why this is we can explain by gravitation. One reason is gravitation. The head being heavier comes down to the bottom. This is one reason because of gravity. Head weighs more, so head comes to the lower position. That is near the this is the uterus. This head becomes here, and so this occupies near the internal os. The second reason for the cephalic presentation is adaptation. The smallest circumference of the flexed head is flexed. I have shown the image in my previous video. That is head is flexed, so it will be having smallest circumference of the flexed head, that is about only 27.5 cm. The circumference of the breech, the buttocks, both the thigh flex is more. You know, obviously buttocks will be more more width than the head, so that is 32 cm buttocks, which is more than the 27.5 cm. So cephalic presentation. This is one of the reasons. Thus the cephalic and the podanic poles can be comfortably accommodated in the narrow lower pole and the wider area of the uterus respectively. See, this is the uterus. This is a narrow lower pole and this is a wider area of the uterus. So buttocks can occupy here and cephalic head can come here. So this is the most convenient way. So the two reasons I told, one is because of gravity, this is the uterus, and the cephalic presentation head will be there, and this is our buttocks because wider area is diameter is less than this. So it occupies the wider part of the uterus. This is a narrow part of the uterus, not a pole of the uterus, and because of gravity, the head is heavier, it comes down. These are the two reasons for why cephalic presentation is there. Next we will go to the methods of obstetrical examination. Now we have come for examination. Examination will be having inspection, palpation, auscultation, all those. Now we'll see methods of obstetric examination. Abdominal examination. A thorough and systemic abdominal examination beyond 28 weeks of pregnancy can reasonably diagnose the lie, presentation, position, and attitude of the fetus. Before 28 weeks, that may vary. So after 28 weeks, we can identify the lie, presentation, and position which we learned till now, and attitude of the fetus. It is not likely that the lie, presentation of the fetus might change because this may be like predominantly after 28 weeks may fix, but still there are chances that the presentation may change, especially in associated with excessive liquor amnio, that is polyhydramnios, and hence especially this lie of the fetus might change, especially in associated with excessive liquor. Hence the periodic checkup is essential in order to detect the lie, presentation, attitude, and position of this thing. Preliminary is what we have to see. Verbal consent, like before examining these things, preliminaries we have to do. Verbal consent of examination should be taken. The patient is asked to evacuate the bladder because the position of the uterus because of this bladder full will raise and it gives a false age of gestation. So we have to ask the patient before examining in order to evacuate the bladder to get the proper fundal height and all those. So the patient is asked to evacuate the bladder. She is then made to lie on the dorsal position with the thighs slightly flexed. The reason why thighs are flexed because it relaxes the abdominal muscles. So the abdomen is fully exposed and we have to expose the abdomen from pubic symphysis to the xiphisternum. You will expose. The examiner stands on the right side. Always whenever you are examining the patient, you have to stand right side of the patient. Now you are inspecting. You are seeing and then noticing what are the things, the changes that are seen, like everything is normal or not. Inspection you have to note whether the uterus is ovoid in shape, is longitudinal or transverse or oblique. These are the things you have to see. Ovoid is longitudinal ovoid, transverse or oblique you have to see in inspection. Next. Concounter the uterus, fundal notching, convex, flattened, anterior wall, cylindrical or spherical shape. The shape of the uterus you have to see. Next, undue enlargement of the uterus. And, the size of the how big the uterus is there you have to see. For that is for fundal height and all you just see, and you see the for umbilicus. You have to see whether undue enlargement of the uterus means abnormally large uterus is there or not. You have to see. In case of polyhydramnios, you see more fluid and then the uterus will be abnormally enlarged uterus. You see. Then pigmented changes, that is this is umbilicus, this is a pubic symphysis, this is a linea nigra, you see stria gravidorum, stria albicans, like previous pregnancies, all marks, you see surgical scar, you see surgical scar, and you see that these are the pigmental changes in the skin, and skin condition of abdomen evidence may infection of ringworm is there on all this you see by inspection, and any incision scar mark of the abdomen which indicates the previous LSCS, lower segment cesarean section. This is indicated by the previous scar marks. All this you see by just looking at the patient's abdomen. Then palpitation. Not patient, like you need to be careful. You should not mention patient like me, and you have to mention as a pregnant woman, as the pregnancy is a physiological process because the examiner may catch you in this point. So you have to be careful while presenting the case. Next, palpitation. Going for a palpitation, you'll palpate for the height of the uterus. And this is a pelvic brim. At the pelvic brim, it corresponds to the 12 weeks of gestation. At the umbilicus, it corresponds for the 24 weeks of gestation. If the fundus of the uterus is at this level, it corresponds to the 12 weeks of gestation. Age of gestation or weeks of gestation, and near the xiphisternum it corresponds to 36 weeks. So 12 ones are 12, 12 twos are 24, 12 threes are 36. If it's at the pelvic brim, the uterus fundus of the fundal height of the uterus is at the pelvic brim, then it corresponds to 12 weeks. If it's near umbilicus, it's 24 weeks and 36 weeks. After 36 weeks, again, because of the engagement of the head into the pelvic, the height of the fundal height will decrease. So I said this is a pelvic brim, 12, 24, 36, umbilicus and xiphisternum. After 36, this is 40 also will come down because of the engagement of the head into the pelvic brim. So the fundal height will decrease. And between this 12, 24 and 36, for every one finger, 1 week of gestation is increased. So you will calculate by using your fingers. How many fingers you count the number of fingers between the pelvic beam and the umbilicus. So the number of weeks you will get. This is a 12 means if 2 finger gap is there. This is a 12. If 2 fingers gaps is there, it's 14 weeks. Like that you can calculate. And you have to see whether the gestational age of gestation according to the LMP and this fundal height is corresponding or not, or any abnormalities is there because maybe because of wrong date or maybe because of any abnormalities like oligohydronimus or all those conditions. You'll see that there is a different age or patient only might have given wrong date, or else during any like other bleeding they may count that as the last date, but that might not be because of implantation bleeding. Implantation bleeding during implantation also they will bleed. That they may consider as last menstrual period. So the wrong dates, because of wrong dates, the fundal height may vary. Next, coming for palpitation. Sorry, palpitation I was saying the height of the uterus is to be centralized. First, the uterus is to be centralized. If it is deviated, you have to use your hands and then centralize the uterus. Then to ulnar border of the left hand, because you will be standing on the right hand. Left hand will be more convenient. Left hand of the ulnar border of the left hand is placed on the uppermost level of the fundus, and approximate duration of pregnancy ascertained in the terms of each weeks of gestation. Alternatively, symphyso fundal height, that is SFH, can be measured from using tape from the pubic symphysis to the fundus, height of the fundus. There are conditions where the height of the uterus not correspond with the period of amenorrhea. These conditions are, I already said, the wrong dates and all those. The condition where the height of uterus is more than the period of amenorrhea, that means, like if it is the 24 weeks, it's showing 24 weeks, then near umbilicus is there, but according to LMP, it's still less than 24 weeks. So the fundal height is more than the age of amenorrhea. The condition where you see like this means, in case of mistaken dates maybe dates maybe that they're considering as LMP prior to the like what we are getting, that may like cause this mistaken dates of last menstrual period. Or in case of twin pregnancy, even though LMP is correct, twin pregnancy uterus will be enlarged more than the normal, so you will get the height of the uterus will be more than the age of amenorrhea. Twin pregnancy or polyhydramnios, which I already said, fluid will be more, so uterus will be more than the normal, and you'll see the height of the uterus will be more than the age of menorrhagia. And big baby, macrosomas and all, big baby also, like, obviously the size will be more. Pelvic tumors like ovarian fibroids, myoma, iridocyte mole, and concealed accidents, all this causes the height of the fundal height will be more than the age of amenorrhea. Next, when the other condition where the fundal height is less than the period of amenorrhea, now small baby, oligomenorrhea, all those will come. Mistaken date for last pregnancy, again here period of amenorrhea is more, so LMP they are considering before than the usual. So this is one mistake, like mistaken dates of last menstrual period LMP. Or scandalica, this is oligohydronimus, or fetal growth retardation will be there. Fetus size will be usually less than the normal. There you see the fundal height will be less than the age of amenorrhea. Then intrauterine fetal death also, after death the baby may become small because of lack of growth. Rupture of membrane, you will see the loss of all fluid, and then fundal height will not correspond to the age of amenorrhea. Next, coming for obstetric grips. Obstetric grips or eupodal maneuvers. A palpitation should be conducted with utmost gentleness. Clumsy and purposeless palpitations are not only uniformity. Clumsy and purposeless palpitation is not only uniformity, but may cause undue uterine irritability. This causes irritability, so it should be when we are palpating, we have to palpate gently. During this Braxton-Hicks contraction, that is uterine contraction in the labor, palpitation should be suspended. We should not palpate during the contraction in case of labor. Fundal grip or first euploid. The palpitation is done facing towards the patient's face. This is a patient who is lying. You have to stand near this is right side and this is the left side. You have to stand near in the right side and you have to face the patient's face. Well, you are examining the fundal grips. You are doing fundal grips. Palpitation is done facing the patient's face. The whole of the fundal area is palpated on the using both the hands, lie flat on it to find out which pole of the fetus is lying in the fundus. Which pole will lie, whether cephalic or buttocks, or like cephalic presentation or breech presentation, where the head or the buttocks lie in this thing. Broad, soft, irregular, mass suggestive of breech presentation. That is, the buttocks are lying in this position. Soft, buttocks are soft. They're broad, they're soft and irregular. Whereas smooth, hard, globular, mass suggestive of head. Head is the hardest skull will be there. So this suggests the head. The transverse lie, neither the fetal folds are palpated in the fundal area. Fundal area in transverse, like baby is lying in this fundal, you won't palpate anything in fundal area. You won't palpate anything as the fetus is lying horizontally. Transverse. Next, we'll see the lateral grips or umbilical grip. Second, euploid. The palpitation is done facing towards the patient's face. This is the patient. You have to stand on the right side and then face towards the face, and then you have to palpate using both your hands. The hands are placed flat on either side of the umbilicus to palpate one after the other, the sides and the front of the uterus to find out the position of the back and the limbs and the anterior shoulder. The back is suggested by smooth, curved resistance you feel. The limb side, compared to the limb side. The limb side is comparatively empty. There are small knob-like structures. These are hands, small knob-like structure of irregular parts or irregular parts. After the identification of the back, it is essential to note the position, whether they are placed anteriorly towards the flank or placed transversely. You have to see. Similarly, disposition of the small parts, whether they are placed on the one side or they are placed anteriorly, occupying the both sides. To be noted, the position of the anterior shoulder should be felt. It forms a well-marked prominence in the lower part of the uterus above the head that may be placed near the midline or well away from the midline. This is a diagrammatic representation of fetus in a fixed attitude. VP represent vertico-podal diameter. TT represent bitrochanteric diameter. Then A represents biacromion diameter, acromion process, trochanteric process. Biacromion, PP, biparietal bone, biparietal. Bitrochanteric diameter, biacromion, biparietal diameter, and ventricopodal diameter. These are the diameters you need to measure. This is all about causes for the cephalic presentation and the longitudinalized predominance. And in obstetric preliminaries and inspection, palpitation and obstetric grips. Obstetric grips, still two are left, the first pelvic grip and second pelvic grip, that are next video. If you find this video helpful, please do like, share, subscribe to the channel. If you have any suggestions, let me know in the comment section. Do comment. Bye.